Hello, everyone. I'm Ron Rolfing, your host of the ACAP Preferred Education Series, and I'd like to welcome you to our latest session presented by Tony Healthcare. Our presenters today are Dr. Sam Toney, CEO of Tony Healthcare, Dr. Roberta McNeil, CMO of U.S. Family Health Plan, and Dr. Christine Messer-Smith, CMO of Denver Health Medical Plan. And they're discussing transformative strategies in medical management delivery, striking the balance between delegation and integration. But before we get things started, I have a few housekeeping items I need to take care of. This webinar, along with all ACAP calls and webinars, will be held in accordance with the ACAP antitrust guidelines. And these guidelines can be viewed on our website. We will be recording today's call, and we'll post the slide deck and recording on our website by tomorrow morning. And the link to these items can be found in the invitation sent to you for this webinar. And please remember, if your plan is looking for a preferred vendor, check out our list of preferred vendors on our website. Just look to the top of our homepage and click on the preferred vendors link. You can also post an inquiry, an RFI, or even an RFP on the Preferred Vendor Connection portal, also located on our website. During today's session, you can ask a question at any time by clicking the Q&A icon in your Zoom window and typing in your question. And we'll take care of the questions at the end. So now I'd like to pass over to Sam to get us started.
Very good. Thank you, Ron. I appreciate that. My name is Sam Toney. I'm a psychiatrist by training. I have spent the majority of my career in the managed care industry, working on building various programs, including programs, case management programs, population health, and so forth. And I'm excited about today's discussion. We're going to be talking about various methods and models to deliver medical management, including utilization management, case management, population health, disease management, and so forth. And we'll be talking about the pros and cons of the different models. I wanted to make a comment here that Dr. McNeil is one of our speakers, one of our guest panelists, but she has not yet arrived. So hopefully she will. But in the meantime, Dr. Messer-Smith and I can have this discussion, and I believe we can deliver some important talking points to you, the audience, and hopefully answer your questions as well. So let me turn this over to Dr. Messer-Smith for her introduction.
Good afternoon or good morning, wherever you are. I'm Christine Seals Messer-Smith. I'm a family medicine physician by trade from Oregon. Just happened to go into private practice there and happened to get involved in healthcare during the expansion and the CCO work. And have been in Colorado for the last 4 years, working with Denver Health Medical Plan as their CMO. We've had an exciting venture from beginning to end, and it really fits well with what Sam wants to talk about today. That is delegation of activities or integration or consultants, however you use them in your organization. So I'm excited to talk a little bit about how we chose to use different opportunities for our and CM teams.
Thank you, Dr. Messer-Smith. And I believe Dr. McNeil has arrived. If we could move to her slide and have her do an introduction. Dr. McNeil.
There she is. If she would, Dr. McNeil, just unmute yourself and you can continue.
Yes, good afternoon. Thank you, everyone. I do apologize for being a few moments late. My name is Dr. Roberta McNeil. I am the Chief Medical Officer and Senior Vice President for the U.S. Family Health Plan, which is a TRICARE option. So we deliver in all civilian network benefits for our member beneficiaries who are active duty dependents and retirees of the armed forces, Army, Navy, Air Force, Marines, Space Force, National Guard, and the Coast Guard.
Thank you, Dr. McNeil. Appreciate that.
Thank you.
We're going to go ahead and jump into our discussion here with some questions. And the first one I'd like to pose is really thinking about your overall design for and CM in your respective health plans. When you looked at those needs, what were you seeing as challenges as they related to, building a team, delivering the service, et cetera. Maybe I can go to Dr. Messersmith first, and then we can move to Dr. McNeil after that.
Sure, it's a loaded question. I joined Denver Health Medical Plan actually as a consultant to begin with. Sam, you're aware of that, because the plan at that time had decided to outsource their care management and utilization management. This is when we started talking about this presentation, I think it's really important to point out that many times we don't have a strategy about what we outsource or insource. Often it's the fire we're trying to put out. And Denver Health Medical Plan had some challenges around utilization management and care management and couldn't see a path through. So they made a decision to outsource. They were halfway through the outsourcing when the entity they were outsourcing to decided to close that particular product or service, and they had to re-insource. So it's not unusual to come up against a situation where you don't have the resources, you decide you're going to outsource, and then you have to backtrack or reverse. So I actually came to the table to help with re-insourcing, meaning building up the utilization management and care management teams. So the first thing at that moment is to assess the resources. What do we have? What don't we have? And then fill the gaps. So one strategy is to look at a gap analysis and outsource subject matter expertise. At that time, we could have chosen to do all outsourced, but they had just done that, right? So we chose to do what I would call a mixed model and hire a team that had the subject matter expertise while using some of our own team in utilization management. And the strategy was to bring in subject matter experts, train our team up, and build it over a period of time, and then let go of that external resource. That was what we did in utilization management. I did the same thing a little bit in care management as well, where you try to bring in some subject matter expertise and build the team up. But for the most part, we focused on it in UM, where we actually chose to have the inpatient services outsourced to consulting, and we used Tony Consulting. And then slowly, and they used our systems. So this is one model where they, in some settings, they might use their own systems, and ours, they used our systems, developed our processes and our workflows, our policies, procedures, job aids, and then slowly trained individuals on the team. I'll pause there. So that's what I would call an integrated model, but transitioning over time model. So that's the strategy. We want to develop our own subject matter expertise, and we're using an outsourcing model to develop that expertise.
So it's basically an evolving model over time with some hybrid approaches, and then eventually you're wanting to get to that point where you have all of that expertise in-house, is what I'm hearing you say, I think.
Yes, and then absolutely. And that's one strategy. Some people might develop a system where you stay integrated for a period for forever. It also sets us up so that we have a backup plan. So that if we all of a sudden had 5 people leave, or all of a sudden had a new program, that we have a relationship with an entity that we had previously outsourced to that we could call upon or build on if we needed it. So it sets us up for that plan B as well.
Great. And I do want to make a quick comment about the terms insourcing versus outsourcing. We may actually have some variations on those themes, and I'll talk about that in a moment. In other words, outsourcing we typically think as a delegated model. Insourcing can either be your own employees, or it can be a hybrid model, as you just mentioned, Dr. Messersmith, where we have some outside staff support and complementing the internal staff on the system, on the native system of the payer. So we'll talk more about that. Dr. McNeil, maybe we can turn to you for the same question and ask about the challenges that you saw and experienced in developing and delivering these programs.
Okay, thank you for that, Dr. Tony. So our experience at St. Vincent's was a little bit more challenged. My first day of work here, I was informed that our current UM vendor decided to terminate us with less than 6 months to find a new platform. So we were able to quickly pivot and to find, and we did identify your organization that was able to come in. And so one of the things that we saw was that we didn't want to do a delegation, and we did want to do it as an insourcing. And so we really work, and we pride ourselves with working with your group on really an in-source but it's a unified model, right? So although it is in-sourced, it is your employees, they work very closely with us and with our team. So it feels very much as if they are, my employees as well. And so we were very happy that we were able to do a partial integration of that workflow, subsequently a full integration, which happened as of November 1st, due to the successes of your organization and the way that you worked with us at our plan. So we do feel very much that your employees are our employees, and we work very closely. We round together, so we really make sure that it is not actually delegated. Everything goes through your senior clinical manager, works very closely with our VP and with myself and our other medical directors. And so we are really happy that we were able to really work with you guys and expand the offerings and really integrate you even more into our workflows.
Thank you, Dr. McNeil. And this really brings up a good point, I think a good segue to ask about the benefits versus the risks of delegation. And typically, I think we all have experienced delegation where there's typically a third party, obviously, with a call center, and the authority is delegated to them, whether it's case management or utilization management. And typically those things are sometimes a bit fragmented, but I'd like to hear from maybe Dr. Messersmith first, if you've experienced that actual full delegation or even partial delegation, and what you saw as maybe the benefits of that versus potential risks.
Yeah, that's a great question. We're a small organization, about 130,000 members. In that setting, delegation would distance us from the members. So one of the risks of delegations is that distance. There are certainly some advantages to delegation. You know, there's a little less worry, but you can't get rid of that accountability. This is very hard if you distance from the responsible party is distanced from the accountable party to try to figure out what you want to change. So I would say that in general, our philosophy is to hold the accountability and responsibility, which would mean that we don't like to delegate fully. Now, we have some relationships where we do within credentialing, for example, and that tends to work really well. There's good oversight, but you still spend quite a bit of effort in that oversight. And so I like to pivot, be agile. In a small plan in particular, we have to move quickly in order to do that. For us, the integrated model works better. Having someone that you think of as, I liked your description, Dr. McNeil, you think of them as your employee, you're having conversations real time, you're making changes real time. So it makes it a little bit more agile, flexible, malleable, which I think is really important for a small plan to maintain for us anyway, to maintain the market share.
And what about the, you talk about the distancing, what about the information platforms where all the data is housed in a delegated scenario? Was your experience that there was a separate system on which these workers would use?
So within Denver Health Medical Plan, we haven't had a delegated relationship for UM and CM. So
right.
In fact, it's the reason we chose not to have the consultants work in our own systems was extremely important to try to fit between two. I'm a clinician by heart. We all talk about our own electronic health records. And if you are an Epic lover, then you want everything in Epic. It's similar for a plan. My clinicians, our case managers, UM managers, they want everything in one system. They need to be able to manage that like a patient, not just a member. So it was extremely important to us that anybody that we have doing utilization management or care management, regardless of who they are working for us, working with a contracted entity, have access and document within our systems. So it's a huge and important piece. If you're big enough, and I would say big and powerful enough to figure out how to share data effectively and can create interfaces that would work well, it is potential. I mean, there's possibilities there, but historically that's really challenging. So I want everybody in the same systems, so they're seeing the same things.
Yeah,
So
that's important. Dr. McNeil, what about your perspective on this?
So our situation, I think, is even more challenging. So we are, our main regulatory reporting body is the Department of Defense Health Agency. And so as such, they are particularly sensitive about any type of delegation, any delegating agreement, anything that we do with any vendor, be it partial or a complete delegation, they must be located on U.S. soil. So that actually is a unique and special challenge for us, which is really one of the benefits of working with your company, in that we were able to integrate the staff right into our systems. So they have our emails, they're entering into our platforms, they have access just as our regular employees do. So it's seamless. We made sure that they are literally working in the same system that our care managers, who are our CBICS employees, are working. So there is no issue about anything, not even an encryption of an email, because we're all working in the same system, which is very important, because we have, I would say, a lot more IT oversight than any plan that's commercial or Medicare, because the Department of Defense is so stringent about what they look at in terms of how any information or any member information is shared. And so it's really been beneficial for us to be able to work with the Tony team, in that everything down to your access in the laptop, we are all working and operating in the same system. This plan did have arrangements with delegation with some other entities previously. We do have another service, PTOT, which is delegation, and they do handle first level appeals for us. And we do notice some challenges when we're trying to have conversations about a member needing something in or out of network. And then we are really working to make sure there's no delay in services for the members, because these are member lives, right? They're not just numbers. And so I can say the benefit of working with the way we work with the Tony team now is there's no delay. Like, as soon as I'm emailing, or as soon as our claims group is emailing, everybody's on it and responding. And so I don't even know that the members have, and we work as one body. So that is really the beneficial part, the most beneficial part of having a fully integrated system.
Thank you, Dr. McNeil. And yes, we've been hearing the word integration, and I think also what I've been hearing in the industry too is dedication. So interesting, you've got delegation, dedication, and integration. And I think in what we've been talking about here with the models that both of you using with a sort of an internal, in-source, but integrated model, it's also having, I guess, the comfort that the team members are dedicated to your plan, to the work that needs to be done for you. And the only reason I'm mentioning that is that, again, and I've been in various environments myself, and I know that sometimes in delegated environments with call centers, there may be sometimes sharing of resources between clients and plans, and it can sometimes lead to issues. So that certainly could be. Dr. Messersmith, you talked a moment ago about pivoting, and that's one of the key questions that we were thinking about when we were thinking of this presentation today, pivoting back and forth. Can you just maybe take a little bit of a deeper dive into that, and how did it work, and were there any challenges with pivoting?
Pivoting is always challenging. Maintaining agility is always challenging. I tend to plan out multiple different strategies all at once so I can pivot between them. You plan a trip and you plan 3 routes. It's similar here. For us, ensuring that we have a strategy moving forward to have a solid team to do the work, ensuring that we have, I will call it augmentation, just for a moment here, augmenting either the subject matter expertise, the service, the literal feet on the ground service being provided, was our strategy. So we have a core team, we augment with this service, and then we ebb and flow a little bit until that team can grow. That was the strategy for UM and CM. In credentialing, I've used a slightly different strategy. I actually outsource some or delegate some of the functions for credentialing. Not in a normal delegated arrangement, but I have a CVO. But I've used the same philosophy we did in UM and CM and applied it there, where my options were completely give up everything, give up just portions, or keep everything in-house. And I've chosen to give up portions, but maintain accountability, which means they're really functioning like, they're augmenting, right? They're functioning like a team that can actually take up slack, so to speak, in the setting of credentialing when you have a boom of needing credentialed providers. Well, it can be similar in UM and CM. January is a horrendous month, for example, or we might have an expansion. So developing for me, the strategy is to develop systems that can kind of ebb and flow with that demand. And integration strategies can get you there if you tend to have huge fluxes or perceive that you will have a huge flux. That's a little different than your question, I realize. I realize you're asking, the challenges of pivoting, right? Well, my strategy to be able to pivot in the future is to embed some agility into the system, some ability to ebb and flow. So I'm trying to make us resilient to that, to change in the future.
Understood. No, I appreciate that. And actually, I have a follow-up question. I guess I'd like to start with Dr. McNeil first and then come back to you, Dr. Messersmith. But Dr. McNeil, are there any particular, I guess, activities or functions in the medical management arena, or maybe not even in the medical management arena, but what I'm trying to understand from certain plans is, are there certain things that you would really be very hesitant to delegate or not delegate? Let's talk about delegation and also using external resources in that manner, or versus things that you feel are absolutely, core and that you would really be very hesitant to utilize external support for.
So that's a really good question, actually. So we started initially with working with your team, and you handled a portion of our function. And so there are some things that we do currently delegate out, which is part of our challenge, right? So I do like the way you describe that, Dr. Messersmith, as an augmentation, as it were. So one of our internal challenges is related to mail and mail fulfillment. And so one of our challenges, and we do currently delegate that to your organization, because we simply, based upon our size and location, we just could not do the mail fulfillment. We couldn't process it. And so ideally, yes, we would like to have mail fulfillment housed in-house to give us the ability, of course, to perhaps reprint a letter very quickly. But we were able to start with one level with your organization and increase and augment, basically pivoting when we saw the challenges with having a piecemeal, as it were, partially delegated, partially integrated, and then subsequently your team was able to come in and do a integration of the function, basically from intake to mail fulfillment, and include first level appeals. So we've been able to pivot, augment what we needed to do and what we needed from your company. But I would say in an ideal world for our plan, we would like to have mail services actually not delegated, to have that in-house, because we do subsequently then have a piecemeal. We have what we do for but then we may need mail fulfillment for marketing or for provider relations. And so we're contracted with separate entities for mail fulfillment and campaigns, and that's a little bit challenging for us.
Appreciate that. Thank you. Dr. Messersmith, what about from your perspective on what the things you would consider to be more core?
Yeah, I agree. It's a good question. It's an interesting question. It's challenging to think through, what would I not want to give out? So what are my strategies, or what's my philosophy here? Dr. McNeil, I agree about this piecemeal thing. So in general, I would say things that you have to piecemeal out would ideally not either be delegated, or you'd find ways to combine them. That frequently happens, that we delegate piecemeal because we have a challenge in front of us, or we're faced with a pain point or something we can't accomplish. So that's a really great tagline for that decision making. But I'd say in general, there's nothing I wouldn't consider delegating, but we tend to sit on the side of not wanting to delegate. So I'd say there's most things I don't want to, and we only delegate if it makes sense, if we can find a value add, and if we can control it. So I'm going to say a real scary word here, right? I'd like to be able to control what's happening. So I would prefer not to delegate things unless we are able to transparently have some control over those processes. So we want to maintain accountability and responsibility and get rid of some of it. And how do you do that?
Exactly. Yeah, and I think, a theme that I feel is emerging from this discussion is when we're talking about delegation versus, internal staff, or even utilizing external support, but not in a delegated way, that there are safety controls in place there, it sounds like, where in terms of delegation, I'm wondering, what some people have talked about with delegated models being that they're on disparate systems is fragmentation of information and data. Also, heavy burdens on the IT departments for uploading a lot of things like eligibility, right, and all the various data files that are necessary to perform these functions. So makes a lot of sense. I just had a follow-on question. It relates to feet on the street or boots on the ground, however you want to say that. Particularly in the case management area, we have, some plans are certainly utilizing a centralized telephonic case management model, but there are also some hybrid models where there are some face-to-face case management scenarios. I guess, Dr. Messer, let me start with you. How does it work with your plan? And again, resources for that, are any of those external, or most of them internal?
Yeah, we're a little, well, I'll say first and foremost, we started rebuilding our care management team in October of 2019, which means 4 months after 4.5 months after we started rebuilding the team, COVID hit, which entirely changed our strategy. We were feet on the ground, contact with members, and pivoted to an entirely remote structure and have stayed that way. Doesn't mean we will stay that way forever, but that means our current structure for interacting with members is really only telephonic. And as of, trying to remember how many months ago, video as well. So we have some video capabilities for our care managers. That's been somewhat limiting in what we can accomplish. It is helpful in creating the team. So getting that subject matter expertise, hiring, finding people that are interested in working remotely, that expands that opportunity, but it also limits what they can accomplish. So there are some key factors in what we've done. The majority of our care managers at this point are employed, but we have retained a small handful from the historical contracted setting. And because they're trained and embedded, completely integrated, that model's worked reasonably well, and it allows for some flex. Right? So if we were to have to contract quickly or expand quickly, we have plans to integrate tools to communicate with our members a little bit more effectively via text, and to drive some of our programs more effectively with other communication tools. But I would say that it is one of our limiting factors right now. We have to get into feet on the ground, into the hospital setting, into other settings in order to make some of the changes that we'd like to make. And if I were thinking through, well, how would I accomplish that if I wanted to work with someone else? Well, so here's the challenge. If you bring someone else in that setting, relationships are the most important key piece here. So if I brought someone else in, it would have to be someone else that had a relationship with the hospitals that I want to go into, for example, in that setting, or the clinics that I want to address. So I might have some opportunities there, but I really would have to strategize around where do they make the bigger difference. And that's the challenge, spending the time to strategize around it and figuring out where it would help and where it wouldn't.
Yeah, don't always have the luxury of a lot of time, right, to get these things thought through. Yeah.
Yeah.
Dr. McNeil, what about you? I'm not sure that your plan is using any feet on the ground or so forth, but what about when it comes to case management, care management, as opposed to UM?
Yeah, so our care and case management actually had been delegated prior to my coming on with St. Vincent, and subsequently, similarly to what Dr. Messersmith described, hired a care management team right in the beginning of 2020. And so when I came into the plan in 2021, our care and case management, everybody was remote at that point, of course, but they were all of our employees. And so they do work with our members virtually. We have also added behavioral health care managers and a social worker to our group. And so they actually do go out and meet with members. We've done a couple of things and events. As we're emerging from COVID slowly, we are trying to have more face-to-face interactions with our members, which they are clamoring to really work with that. This plan had not ever had care managers that were employees and that were doing that face-to-face. A lot of the face-to-face meetings were only relegated for operations and provider relations, actually going into hospital systems. So it's kind of a new idea. And so we are pivoting slowly, but surely as to how we can, kind of change that and make it more of a hybrid model. So we have started with our behavioral health care managers to actually go out and meeting and doing some workshops with members at some of our practice sites, which has been working pretty well.
I wanted to add to that, what I'm hearing us say is we have used outsourcing, delegation, hybrid models, whatever you want to call it. We've used it for change management.
Right.
Mhm.
We've used it to meet a need, clearly, but we've also used it to change culture, change
Yep.
tactics.
Right.
I say augment, but it really means to pivot. It's a great pivoting strategy. You're bringing other people in that have different subject matter expertise that might have a different cultural perspective to try to drive things in a slightly different direction.
Absolutely.
Yes.
One use.
Yeah. Well, and you mentioned behavioral health, Dr. McNeil, and I'm just wondering a kind of a follow-on question to that. Are there any particular one of the reasons that health plans may elect to either delegate or elect to bring in outside resources for certain things would be the nature of the clinical profile of the service. In other words, historically, a lot of plans did delegate and outsource, if you will, behavioral health. I know that some are doing the same with DME and some with diagnostic imaging. What about those drivers for thinking about external support, whether it's delegation or whether it's external support through like a hybrid model? Does any of that come into play when you think about what should be done as a core? Or?
It's very funny that you mentioned that. So I've been in conversations with that. So our behavioral health is delegated 100%. And so to tell you that it has not been a challenge would be untrue. It is extremely challenging. One, because we're dealing with a group that has a national footprint, and it is challenging to kind of get some of that one-on-one that we feel that we need. Secondly, the Defense Health Agency is very sensitive about post-traumatic stress disorder, suicidality, a lot of things that disproportionately affect veterans and their families. And so the mere fact of having and establishing or being in an area for 2 or 3 years before you get deployed to another new area where you don't know anyone, you have to pick up all over again, makes us very sensitive to some of the needs, unique needs that our beneficiaries have and that they've served our country. And the dependents, while not necessarily in active duty, they're also serving, right? Because they're responsible for, keeping things going while that family member, the sponsor, as we put it sometimes, has been deployed. So we are in conversations actually actively on how we can go about doing more of a hybrid model. What does that look like? How can we integrate? We've already done and started the legwork with integrating and having a behavioral health social worker, care manager, who's on staff, who has really transitioned into becoming the subject matter expert of our department. But we found subsequently so many other needs for our members that we had to hire a social worker as well to assist us and to assist her with some of the other things, the social determinants of health, some of the things that, our vets are facing with the living expenses, et cetera. And so it's really grown into the fact that we're seeing we need even a bigger hybrid, if not moving towards a full integration of that benefit, and probably with some support as it relates to a psychiatrist assisting us, some of that intake, because the majority of what we see that we need are actually not inpatient services for behavioral health, but finding the substance use disorder, finding the therapist, finding the partial day programs. Those indeed are challenging. And so having psychiatrists and having a staff on that can really work with members at that level. We don't have a lot of serious mental illness simply because the military kind of self-selects. And we don't see a lot of that, so we don't have a lot of inpatient behavioral health admissions, but we are seeing some anxiety and some eating disorders in the dependence of our member beneficiaries. So we are moving forward towards an increasing level of hybridization, as it were, and we've been outreaching to a few agencies, yours being one of them, as to what that could possibly look like for us. and how we could really get the best offering for our plan and our members.
Thank you. Dr. Messersmith?
Yeah, and this is a really interesting topic. I was thinking about substance use disorders. Tony Consulting has talked with us quite a bit about how to help manage our substance use disorder members. We have a large contract for Medicaid, and for our Medicaid line of business, we sub or delegate the behavioral health. It's the way that the structure is in Colorado. And we have some challenges, some strong, large, huge challenges around substance use disorders, the benefit, the way it's structured, managing those members, reaching the members, engaging the members. We have measures associated with them. And the biggest challenge is figuring out, where do we spend the money? How, I can envision all these marvelous plans. Dr. Tony and I have chatted quite a bit about programs that they might bring to the table, meaning subject matter expertise is needed. You can't just stick a standard care manager, can't put a standard care manager on the task of trying to engage someone who's has substance use disorders and has not been engaged in the past. It is really challenging to reach these members, to get them to engage in a conversation about the issue, let alone have them come back. And if anybody's involved in HEDIS, there's an IET measure that measures initiation and engagement of treatment. It's one of ours. So we're really trying to problem solve, and yet it's a costly solution. It's hard to look at what's the ROI to cover those costs. It's probably better outsourced in this setting because you really do need subject matter expertise, but there's some politics around the way these things work. So we've continually been trying to address what the opportunities are and haven't found a path through. So we continue to struggle, I would say. We do a little bit here, a little bit there, a little bit here, and are trying to find some cohesive plan. And I don't have any magical solution there, but it is one area I envision that it's going to take a few years to develop the expertise within the teams that I think would be necessary to engage these members. It also requires pivoting to different mechanisms of engagement. Telephonic's probably not ideal at all. And, showing up in the ED is more likely to be beneficial at the time of an event. And then convincing, from a budgetary perspective, convincing the teams where to put enough money into this and to have it count for what we need it to count for. So I know it's really a tangent, but I think it's a great area to talk about what types of delegation might exist and how one might get there. It's just fraught with challenges and barriers.
Yeah, no, and that's absolutely right. And, I think when we think about either outsourcing, and again, I'm using the word delegation or outsourcing almost in the same vein, but it's typically for, ease of doing it. In other words, especially when maybe there are new geographies or new lines of business that come into play. But it sounds like, from what I'm hearing you both say, is ultimately you would like to control all the pieces, all the moving pieces. You want to have instantaneous information. You want to be able to run reports on demand, which I know can be difficult in situations that are outsourced, especially if they're on different platforms. So having all of that, at your fingertips, if you will. And even though you might still be using a hybrid model with some external subject matter expertise, it sounds like it's something that's more desirable and that you feel a better control of and better ease of monitoring of. Does that make sense?
Hey, we're both chuckling. Yeah.
Yes. Yes.
Very good. Well, I want to make sure we have some time for other questions as well, and I'd like to see about opening up that for anyone in the audience, if there are any questions. Ron, can you tell us how that we should do that?
Certainly. We have questions. If you have any questions, just open up your Q&A by clicking the Q&A icon and typing in your question. We do have some currently. Our first one, what are the key factors you would consider in transitioning from a delegated model to an in-source model? For example, data security, technology and equipment, staffing adequacy.
I can start. For me, subject matter expertise and staffing adequacy was number one first I had to assess what do we have. So I would say resource assessment, number one. That might be tools and software. If you don't have software that you're managing your utilization management or care management in, you have to in order to insource. So you have to have a mechanism to track what you do, and you have to have the staff to do it, and then the expertise to accomplish it. And all three, if you don't have all three of those, you're going to fail. So you have to figure out where those gaps are. And then from the way I talk about this is augment whichever area you need. Or what we did is bring in all of those for a period of time and then slowly transition. Dr. McNeil.
Yeah, no, that's interesting. So in our transition, we literally did not own the software. The complete benefit was outsourced. And so, and in doing the transition to the Tony team initially for the we were given numbers for staffing that were incorrect. And so literally the Tony team was able to pivot. They did some pivoting and reassess what the staffing actually was. The subject matter expertise was indeed there, but what we needed in terms of staffing and literally building out workflows. The delegate that we were working with was very reluctant to share a lot of things, and we were fortunate that the people that were assigned to our plan did have the subject matter expertise, particularly when dealing with TRICARE, which is a very special benefit. And so that helped us a lot. And quickly we were able to right size and see what it was that we needed, how many staffers we needed, you know, and just working with the team and literally rounding. So we do rounds and we do several other types of things, but rounds is the thing that really stands in the forefront of my mind. And it's care management, it's myself, the other medical director, our VP, the Tony team, and it's almost, it's seamless, right? So who's taking on this? The care managers, the nurses, everybody's working together, input from myself and the other medical director. So it feels like it's really one cohesive team as we're discussing, you know, patient issues, member issues, ideas on best practices or how to best work with this member. So for us, the staffing was a big challenge. The knowledge was absolutely there. And the platform was something that we subsequently had to change to. We actually just moved to a new platform November 1st, which has been challenging. And so, you know, what we've seen, because we literally didn't even have our own data. And so it is a challenge if you have somebody who might come forward or provider was asking for, well, I got an approval, what's the, you know, or I got a denial, what's the rationale? We literally had to go put in tickets to get our own data, which is our data, which, you know, but there's a time and there's a time lag. So I would say really as you're transitioning from a delegation to thinking about an in-source, owning your data, and that's everything, your care management notes, your notes, all the clinical things that you wouldn't necessarily think, but are a part of that member's record, right? So you don't want to ever have that transition where you don't have a piece of that. So I would say that owning the data is the third most critical part of that whole transition.
Okay, our next question. If you would, please share your approach and timeline for training supplemental staff or temp staff.
You want to take that one first, Dr. McNeil?
So the training is almost ongoing. As I stated, we transitioned to a new platform as of November 1. So there's been a lot of training that's gone through literally with the staff on learning how to do the first level appeals, which is still a challenge. The CM, a lot of hours have been spent, even in terms of how we're looking to integrate. And I would have to say that the Tony team has been instrumental in literally working hand in hand with our CM team as to how the platform should actually even be built. And so it was very important to us to make sure that we got what we needed. There were a lot of man and woman hours that were engaged in this. And fortunately, the Tony team was able to, I keep going back to the word pivot, but able to provide additional resources for us, because sometimes there were issues with, you know, the system was done. Now when it goes into production, there's another issue, right? So then there was actually more training needed. So the number of hours that were put in were significant on that transition. I don't think anyone really has an idea of the transition from a delegation to insourcing, and just being able to have a team that was flexible, both internal and with the Tony team, has been vital for us.
You did an implementation at the same time. So you're not just pivoting and bringing something in-house, you're implementing software. What software did you guys choose?
So we changed to a platform called Med Decisions. And so one of the things that I saw when I came to this plan as a challenge was that we had disparate systems where information was coming in. So the claims team might be looking at one system. CM and UM was looking at something else. Those two systems didn't communicate. So we had a lot of systems that were good at whatever time, but due to upgrades, or sometimes they never communicated with each other. And so there were a lot of emails and a lot of time, I think, wasted in trying to get to the bottom of an issue, because there was not one source of truth that held the member's record. And so part of my, sometimes I think madness, but some of the idea of actually having our own platform was being able to have somewhere that's the source. So the appeals team can go in and see what came in clinically, right? So the claims team can come in and see, yes, this was done, this was approved. Even if they may not understand the clinical information behind it, they can actually see it and see what it is they mean. The HEDIS team, everyone that touches a member can really go in and see everything that they need. And I think that is, it was a lot. It still is a lot. It still is a lot.
Yeah, it really depends on where you're starting from, how long it will take to train. But I will tell you that there's a couple of pieces of information I do know. So when we take a nurse to do UM who has never done UM before, they may have done UM in a hospital setting, but never worked for a plan doing UM before, we can get them up to 80% productivity within a year. It takes a year for someone who's never touched it to get to 80%. You don't get to 100, what I call 100% productivity, for at least 2 years. So somebody that's really a veteran and experienced in doing UM. 80% productivity is pretty good, but that's a year. So I mean, at 3 months, they're doing some. Now, if you've been a UM nurse before for a plan, that's different. It's probably more like a 6-month curve within a specific plan. If you've been out there with all lines of business and worked Medicare, Medicaid, and commercial insurers previously, still probably a minimum of 6 months to train a nurse on your own systems, your own decision-making process, the wonkiness of each of us as a payer. So that's just a nurse. So imagine it's the director, and I think in this case, it was our manager we were training up. We hired a manager for UM who had done UM in hospital settings for years, but not worked for a plan. That took 1.5 years, and I would say probably a full 2 years before the individual felt confident and comfortable in that position, and they're pretty reasonably strong. We hired a director for UM that had actually worked for us as a contractor for a period of time, for almost 2 years before I moved her into the position. If someone is very trained well within your own system and understands the system, meaning understanding the plan, adding on UM or CM is probably not that difficult. But what we tend to do is take people who have been outside of the plan, who function as an RN or function at this level, and bring them in. So I think it really takes longer than we give credit. It really takes a couple years. If you were going, I don't know how long it took you guys, but if you were going from no software, no teams, you're hiring people and they may be good at this, and yet they still don't know your system. They don't know your workflows, your processes. And if they've never built one before, and that's, how hard is it to find someone who's built one? It's hard, which is one of the reasons we rely on consulting groups who may have done this 15 times before. It is invaluable to have a group or expertise from someone who's done this at least once before, let alone 2 or 3 times.
Absolutely. And that was really vital for us, that We had someone come in who had worked in the TRICARE space before, because our benefits are unlike any commercial. They're not commercial, they're not Medicare, they're not Medicaid. They are very unique. And so someone to have had that baseline experience was really, really critical for us. And help
The answer's a long time.
Some of this. Yeah.
Okay, our next question. When you looked at the challenges or gaps you were facing, how did you make decisions on filling those gaps?
Quickly. I walked in, assessed the resources. I mean, I will tell you, for me, I was hired to come in as a medical director, as a consultant. Within a couple of months, I actually applied for the job, but they had 5 medical directors in 5 years. And the answer for me was they had to make the decision quickly. They were forced to, so we made decisions quickly. And that means, what resources do we have? How many auths are they processing, right? This is data-driven decisions. How many authorizations are we receiving? How much staff do we have? What software is in place? Do we have the tools? I just went through each and every one of those line items and assessed, do we have it? Will it work? Is it a working, it's a little, I was going to say it's a beat up car, but does it work if it functions? And who do we need? What do we need? It's the resource assessment. So I just walked through it one by one, did it in a day, just hammer it out through and through, and made decisions to move forward. And then I will say, I'm not remembering, Sam, when we reached out, but I think to begin with, it took us a little while to reach out and ask for some assistance. I would say, I think it was the first year where we tried to muddle through. And then I reached out when I realized we were getting behind in our inpatient and said, we have to have, this has to stop. So if I had made better decisions, I would have asked for help sooner. We tried to do quite a bit on our own with sort of a muddy system of some contractors and and then put a stop and said, no, we need to actually farm this out, fix the problem, and reassess.
Yeah.
Our timeline was even shorter. So I started in November. My predecessor actually was a vendor who was kind of holding the spot. So it was a combination of COVID and a few medical directors coming in and out. So I think we started, the request for information in December and January. And then the Tony team came on board April 1st. And so the time when I tell you it was short, it was extremely short. And subsequently to move into within under a year of a full integration of using the Tony team. So it has been a very rapid pace. The delegation agreement that we had before, the staff was not clinically strong, right? So even if you knew, and I think that's some of what had happened working with this company that have this large footprint, they weren't clinically strong necessarily about some of the things and that we thought that they should be. And so we were able that when we did the transition, we did have nurses that were, even if they weren't necessarily familiar with this model or this, this TRICARE benefit, clinically the knowledge base was there, that they understood what they were looking for, they understood what to ask for, and some of our nuances of, okay, we need you to refer, these serious reportable right away, right? Because we have a shorter time than most to report these things, and some of the quirks that DHA is looking for. So for us, everything was very rapid fire. I've been with this plan 2 years. And so subsequently, the Tony team has been with us for the majority of my time here, which has been really good for us.
Okay, I think we have one more question here. How did or do you manage oversight of the in-source team versus the delegated model?
Those are great questions. Trying to think back, relationships. I think you have to trust your delegated entities, and if you don't, it will be extremely challenging. So we managed by collaboration, managed by hiring somebody who had expertise and working together with them. There are, I believe prior to our hiring for UM, we hired the Tony Consulting Group to help us with inpatient. Prior to that, we actually had several other relationships that didn't work so well. They were mostly just single consultants that were difficult to manage or didn't bring to the table what we needed. That wasn't what I would call delegation, but it's a challenge anytime you have a consultant. You do have to set expectations clearly. You have to develop the relationship. You have to be willing to be honest. All of those basic things that you would imagine, but I would ensure you have developed some embedded SLAs. That's that clear expectations in contract, not just in word. What is the goal of this project? How are we going to measure it? What's the measure of success? Those are always very helpful things. And then hiring somebody that you trust. It's probably the key for us anyway.
Right. We definitely see, so I see a difference in some of our delegation or delegation agreements. We have more of a JOC where they're sharing things and metrics, but not, the oversight is not there. And then working with the, the Tony group, as I stated previously, I can't understate this, that, we have full-on rounds with them. We have, meetings with the staff that is doing the UM, that's making those decisions. And so, like I said, in our rounds, it's our entire CM, the UM team, behavioral health. So we're really working as one group. And that, I think, has done wonders in terms of, the way, and gives everyone the empowerment that I'm part of this. Like, we literally have shared SharePoint documents that everybody's going through and typing and updating information. And that really has helped us in terms of oversight.
Yeah, I'd say there's formal and informal oversight, right? We'd all like to embed some formal oversight. What is the most successful is often more relational, with as long as you also have that formal layer to back you up if you have a challenge. That's
Right.
I find that interesting and intriguing, right? It's clear expectations ahead of time, ensuring that you have those day-to-day interactions so that you can catch something earlier. And then if you did have a problem, that you've got it embedded in your relationship or your contract.
Right. And we do have in our contract, we do have the SLAs, and we do have our regular quarterly, operational meetings where we're discussing things, issues, and reporting. But that day-to-day interaction and those weekly, sometimes bi-weekly rounds is invaluable.
Makes sense.
Yeah.
Okay. Well, that takes care of our questions for today. With that, I'd like to thank Dr. Tony, Dr. McNeil, and Dr. Messersmith for their time today. And I'd like to thank all the attendees for taking time out of their day to join us. Just a reminder that the slide deck and recording will be posted on the ACAP website by tomorrow morning. So thanks again and stay safe.
Thank you.
Thank you so much. Have a good day.